chose Perio because it's like most things in life, it's about opening your mind up to the possibilities of the discipline. So I enjoyed in particular the technical challenge of the really delicate microsurgery, but I also enjoyed the intellectual or mental challenge, if you like, of the medical aspects of managing all those diseases that present in and around the periodontal tissues. So my practice is 50% surgical, 50% medical. And then from a research point of view, the biological base of Perio is just huge. Every ology you can think about is important in Perio, and so the research is just fascinating. It impacts on all aspects of oral health, general health, and I think we can make a big difference to people in terms of their health and well-being. So best discipline in dentistry, if not medicine, if not the whole of science. Okay, so the 11th European workshop didn't really not recommend flossing as such. That's kind of been misinterpreted by the tabloid newspapers. And what it said was there was very little evidence that it was of benefit for patients who have gingivitis or periodontitis. And the reason for that is it's just helplessly difficult to perform, and waving a bit of string in a space is not going to achieve a lot. So even dental professionals, even periodontists, let's face it, struggle to use floss. You end up cheese wiring your gum and inducing inflammation. So the recommendation was based on the evidence, and the evidence was that incidental brushes are the method of choice because they work and they reduce inflammation and they reduce plaque levels. But where they don't fit, rather than induce trauma, then whilst the evidence is thin, the professional recommendation is to still use floss in those areas. Yeah, define non-compliance I think is the big challenge, because I've been in situations where I've started to have a conversation with a patient about their motivation, only to find that they haven't been educated by the student or the staff member about the disease. They've not been told about their risk and why they're different. They've not been told what their commitment is. So it very much depends upon what the patient has been told. If they've been educated, motivated, shown what to do, can demonstrate they can do it, but aren't doing it, then in that situation you have to have an open and frank conversation, but it needs to be a non-judgmental conversation, because I'm not convinced many periodontists could spend the time performing the various oral hygiene techniques that we expect from our patients. So I think we have to be realistic. And I raise the issue of palliative care with my patients who are non-compliant. And as soon as you mention the word palliative, their ears prick up and some of them start to take it seriously. And if they don't, then they know that they're going to lose their teeth sooner rather than later. And if they do start complying, then no reason they can't keep their teeth indefinitely. It's really difficult with e-cigarettes at the moment because they've almost become cool, haven't they? Let's face it. And the truth of the matter is we don't know yet what the impact is on periodontal disease. There's very little out there. There is, I believe, a NICE report scheduled for next year, 2016. So we might get some kind of indication from that report. From the research that's out there and from the research that certainly we've done over the years, if you look at the biological effects of nicotine and cotinine, they're not dramatic. It's the various other products within the particulate matter of the smoke or within the vapour phase itself that seem to, the hyperthiocyanins and various other toxic compounds that seem to produce the biological effects, certainly in terms of neutrophil function and in terms of periodontal health. So I'd be really surprised actually if e-cigarettes were detrimental to periodontal health, but I honestly don't know. I think we need quite a few more years before we do know. I would say that it's probably unsafe not to probe implants. So yeah, of course you've got to probe implants. There is nothing unsafe about it, provided you're using a gentle pressure, your classic fingernail bed blanching pressure of 0.2 newtons, whatever that is. But relatively light pressure is safe to do, and if you don't do it you won't find the suppuration, which is classic of peri-implantitis. You won't find the bleeding, So you won't see the early stages of mucositis, and you will not know if the probing depths are starting to increase with time, so you will miss a diagnosis of peri-implantitis. And the earlier the diagnosis with peri-implant diseases, the easier it is to treat those diseases, and they're hard to treat. So it's not like trying to reverse gingivitis if you have peri-implant mucositis, it's a hell of a lot harder. So yeah, it's safe to probe, and everybody should be probing, and use metal probes, not a big deal. We have a massive problem with peri-implantitis, yeah, and I don't wish to scaremonger, but when you look at the data and you look at the facts, almost one in four patients with implants has peri-implantitis in their mouths, and we're talking over 60% of patients with implants have mucositis, and 50% of those will go on to develop peri-implantitis. So it's a huge problem, and it's a problem because actually a lot of people who are putting the implants in are not basing their decisions on the patient's history and their risk. They're not basing it on the evidence from the literature, and many haven't actually done sufficient training in order to be putting those implants in safely. It's not necessarily the surgeon, doesn't mean they're not good surgically. They're not trained medically, and they're not trained periodontally to know which cases are going to fail. And I take a very simple view. If you don't know how to salvage an implant, you can't do the regenerative surgery or perhaps the non-surgical approaches, then you shouldn't be putting them in the first place, because what are you going to do when they fail? Where are they going to go? I'm very biased in my view, and I'm biased in my view because all the failures come to me on the NHS, and I just see disaster after disaster after disaster. And I think if you want to train to put implants in and to manage implants holistically, then you should do some form of periodontal training, because actually it's about educating the patient about their risk factors. It's about educating how to clean that little metal cylinder, which is a hell of a lot harder to clean than a tooth, and then it's about knowing what intervention strategies you've got when the implants start to fail. So if people don't want to do a full end-to-end dent in perio implants, because let's face it, that's probably the only formal training you're going to get holistically, then I would encourage people to go on as many postgraduate courses in perio, and obviously in implantology itself, but I think the perio is more important. The technical discipline of placing the implant is relatively idiot-proof. That's why the systems are being designed that way, to reduce the risk to manufacturers really. But it's about selecting the right patient and putting the right system into the right patient at the right time for that patient. Yeah, perio unequivocally affects general health and well-being. So it can affect mental health actually as well as physical health. And the evidence is pretty robust. There are several studies, I can think of four from 4 different countries immediately, that show that your mortality obviously increases if you have more severe perio disease, particularly if you're male and under the age of 50 when you develop that disease. And the reason for that could be common risk factors, but actually when you look longitudinally at the data, particularly from the Boston studies, but also from the Swedish studies, it's very clear that periodontitis is an independent risk factor. And the evidence for diabetes, I think, is probably stronger than any other systemic disease. The evidence for cardiovascular disease is strong for associations, and that's also prospectively. So in other words, if you have periodontal disease and you then look at cardiovascular outcomes, you have a higher risk of an adverse cardiovascular event if you have periodontal disease. The issue or the difficulty is, what can we do about it? And we don't yet have the hard data for cardiovascular disease. We have data that shows that surrogate measures of cardiovascular health improve with periodontal treatment, but we don't have hard outcomes like reduced numbers of heart attack, reduced bypass procedures, etc., revascularization procedures. But with diabetes we have the evidence. The evidence is very clear that if you treat the periodontitis and you treat it successfully, and I use that word successfully because of course we're all familiar with the Ainsworth study, that multi-million pound study from the States where patients ended up with over 70% plaque scores and over 40% gingival bleeding, and that's not periodontal treatment done successfully. But if you do it successfully, then you will reduce HbA1c levels, so you'll reduce the glycemia in these patients, and you'll improve their cardiorenal outcomes. So there are hard endpoints that will improve, and there's a dose response as well. So yeah, I think the evidence is unequivocal, but there's a long way to go. We're still at the beginning, if you like. There's still a long way to go to find out exactly what that interaction really is and what we can do about it and how successful it is. Yeah, no, it's a really good question. I mean, it's very easy in a secondary care environment. I mean, I probably work with 5 or 6 different medical disciplines weekly. So, you know, with rheumatology, with respiratory medicine, with cardiovascular medicine, with the renal physicians, and dermatology, adult and child dermatology. In fact, we have regular joint clinics. But in the primary care environment, it's more challenging. A, because you're busier. B, because the infrastructure is not set up to achieve that. And C, because there's been a historical resistance, if you like, in medicine. A fear that maybe other sort of medical professionals would move in and steal the work. I can tell you that's not the view now in primary care medicine. I was at a meeting recently, it was one of these Westminster round table debates, and the chairman of the primary care network in medicine was banging the table for dental care professionals in general to start screening for medical diseases in practice, because they can't cope. I mean, GPs are just completely overwhelmed with the work they have to do. And when it comes to screening for diabetes, for heart disease, vitamin D deficiency, for example, lung disease, many of these common problems, there's no reason that couldn't be done in a targeted way in dental practice. It would have to be targeted, or that would be a waste of money otherwise. So that, I think, is going to happen in the future, without a shadow of a doubt, because we see patients that when they're well, we see patients that don't go to their doctor. They go to the doctor when they're ill. We see them when they're well, so we're in a good position to risk assess them, to screen them, and to pick cases up early, or incipient cases in the case of diabetes, and get early interventions organised. It just needs to be joined up, and we shouldn't do it without our medical colleagues being aware and having some kind of care pathway established. But you can do that locally. You can establish a local care pathway. Yeah, the future's bright, I think, in that respect. The BSP, actually, the substantive membership of the BSP has always been general practitioners with an interest in perio, which is really refreshing, actually, because these are the guys that are challenging. They're out there cutting the mustard on the high street where it's tough, and I really admire that particular group of the BSP, because they're trying to do proper perio in a very, very difficult environment. And we still have a section for those practitioners, so it's not just about specialists, it's actually about anybody who has an interest in perio, even lay people. You know, what the heck, it's a very open book, if you like. So young specialists, people who aspire to be specialists, people who just have an interest, why not? I think we are inclusive and always have been. Hygienists, therapists, even nurses who have an interest, oral health educators who have an interest. It's really a society for everybody. I think the challenge is actually arranging meetings so that there is something for everybody. Because if you have a surgical meeting, then that's perhaps not going to interest the therapists as much, or maybe the general dental practitioners as much. So it's a really difficult balance to get right, but we're going to be changing the way that we educate people. Models of education will be changing. There's going to be a lot more webinar-based education, and so I hope we can actually improve our reach and become more effective at reaching each of those individual needs, particularly the CPD needs, by using that type of